To introduce myself, my name is Nupur Singh, and I worked on this project alongside Dr. Hammond, Caroline Reidy, and Dr. Mazumder over here at the University of Tennessee. Um, so as Dr. Nesher had mentioned, that breast implants and all type of prosthetics can often have infections, which is one of the main concerns surrounding their introduction into the human body. So we know that infection can occur during all types of breast implant surgeries. The main sources are often surgical sterile field contamination, skin flora introduction, and contaminations that originate from other bodily sites. So if you have a systemic infection or a soft tissue infection, they can move towards the implant. But in particular, Dematiaceous molds or Dematiaceous fungi are pigmented, they're septate hyphae molds, and they're commonly found in soil and plants. They're a little bit more foreign to human species, but they are very densely found in like the Memphis community within plants and soil. And these fungi can cause a wide variety range of clinical presentations. The most severe presentation is known as phaeohycomycosis. And this case of mold infection of breast implants kind of raises important questions regarding what environmental factors and what patient conditions can help facilitate a more fungal biofilm formation on the external surfaces of breast implants. So to dive into the case a little bit, we had a 55-year-old African-American female with past medical history notable for type 2 diabetes, dyslipidemia, hypertension, and gastroesophageal reflux disease. And she had initially presented with a left breast cancer that was diagnosed as estrogen receptor, progesterone receptor positive, and HER2 negative invasive lobular carcinoma. She was treated for this breast cancer with bilateral mastectomies and had immediate breast reconstruction with tissue expanders. And after that surgery was performed, she had 25 rounds of whole breast irradiation and adjuvant therapies of abemaciclib and anastrozole. And then eventually, after all of this had completed, she had returned to the operating room to exchange the tissue expanders for silicone implants. And that's when the right breast pocket contained an odorless, like turbid fluid, and the tissue had this visible black sediment right here on the bottom, as seen in this photo. And what was interesting was that during this time of having the tissue expanders and after the chemotherapy, she was entirely asymptomatic without any fevers, erythema, drainage, purulence, like basically no signs of overt infection. Of note, she had not ever been on any systemic immunosuppressants or chemotherapies, but her absolute neutrophil count at the time of her diagnosis with this dematiaceous mold was 1,290 cells per microliter, which is significant for neutropenia being under that 1,500. But once this turbid fluid was seen in the OR, they basically took intraoperative cultures, which initially did not speciate in the Methodist lab and eventually was sent out to return as Curvularia simonisi and eventually a separate species of Cladosporium species were both identified. And as a result of this, the initial speciation of some type of fungus, she had been started on voriconazole, 200 milligrams twice a day for 6 to 12 months. And so she was going to continue that. And what I really learned from this case is that there are a whole host of different types of infections that one can get from having breast implant surgery. And in order to prevent systemic infection, for this patient, they went ahead and decided to remove the silicone implants after they had exchanged them for the tissue expanders. And then at that time, the soft tissue capsule had about 10 like black specks that were scattered throughout the pocket. So it showed maybe that there was still further infection there, but there was no evident infection anywhere else in her body. So this case kind of adds to the potential complications of breast surgery that can incidentally be found without any presenting systemic infection concern. So basically, to wrap up, we present two unique cases of two specific dematiaceous fungi that hadn't been reported before to the best of our knowledge, that infected both the expander and silicone breast implants. And the patient thankfully had complete resolution after the implants were removed, and she had this prolonged course of antifungal treatment. So with that, I'll take any questions and would love to dive in deeper if anyone had any particular things.
Thank you very much for that presentation. The implants that are now removed from this patient, and she says to you, doctor, because you are now her doctor, when can I have new implants put in? How are you going to advise her?
I think what it had been about 12 months after the voriconazole dosing that we felt comfortable saying she was free of any dematiaceous mold infection. However, the struggle still remains to understand how much voriconazole can access all different parts of the body. So if voriconazole was able to access her soft breast tissue versus in comparison to just traveling around in the blood. So Dr. Mazumder and I talked about that conversation, and the patient had not mentioned any desire in wanting to go through that process again. But I think in theory, after those 12 months had occurred, and if she was still stable from an oncologist perspective and perhaps no longer neutropenic, since that was the only thing that was semi-abnormal with her labs, I think we could proceed with caution, and as well as maybe taking cultures intraoperatively prior to delivering the implants to verify that there weren't any dematiaceous molds left would be my best guess.